Now let's get into the meat of this series. Starting from this video, we'll be taking an in-depth look at the diseases we vaccinate against. Every video will follow the same approximate formula. First, a brief look at the pathogen. Second, how the disease is spread. Third, how it manifests, its complications, and why the disease is dangerous and important. 4. Vaccine component overview. 5. Special mentions about the vaccine and its side effects. And 6. Weigh the risks and benefits. I feel it's best to start in chronological order, so we'll take an example vaccination schedule and follow it along, talking about every disease as we progress through it. So let's start with hepatitis B. Previously we have discussed a very basic model of how a bacterial infection works. Hepatitis B, however, is caused by a viral infection. And there are two ideas about viral infections that we need to get across. First, based on their structure, viruses are divided into simple and complex. The only thing that you need to understand out of it is that simple viruses can survive outside of hosts and can be transmitted via oral route. Complex viruses cannot survive for long outside of hosts. They cannot survive the gastrointestinal tract and have to be transmitted via other routes. Second, a virus can only reproduce by entering another cell and using that cell's resources to multiply. In order to find and enter those cells, a virus has receptors that it uses to bind. It implies that viruses can only attach to cells that have targets which their receptors can't bind to. So viral infections are very selective when it comes to their routes of entry and organs that they affect. The immune response to a virus is very much the same, with a few clarifications. The virus reproduces inside our own cells. Once the cell makes enough of the virus, it's released outside to infect new cells, which often results in the death of the first cell. Since the virus is inside of a cell most of the time, APCs play a small role in our initial immune response. They simply can't target something inside. Moreover, humoral immunity is also much less useful, as antibodies are unable to reach the virus unless it's circulating in our blood. Cell-mediated immunity is the primary fighting mechanism when it comes to fighting most viruses. Sadly, we can't evaluate how good it is, so we evaluate immunity based on antibody levels. The only truly useful thing that antibodies do is being able to cover the virus's receptors, the ones it uses to enter its target cells. In order to create specific immunity, another mechanism is used by our cells. Our cells, just like any bacteria or virus, are also vastly covered in antigens. Our immune system learns those antigens and teaches every one of its cells to not attack our body. In every human being, those antigens differ vastly. Transplantology as a science only became possible once we found drugs able to suppress a person's immune response. Before that, the immune systems of organ recipients would quickly get rid of the transplanted organ as it possessed different antigens. You see, all of our cells update our antigen data all the time. It doesn't mean that it becomes different, but the antigens get produced anew all the time. Viruses insert their DNA and command our cells to produce certain proteins needed for the virus's reproduction. These are all antigens, and not all of them are used for the purposes that our viruses would like to. Some of them are eventually broken down and also presented as antigens on top of the cell's membrane. This way, our immune system is able to recognize infected cells. For the most part, however, it's not enough to start the immune response. Our immune system always uses double selection for making its cells, so every single one of them is trained to not attack our own body. Unlike bacteria, which can be easily consumed and killed off, the immune system is reluctant to consume and kill our own cells. It goes against its own principles of work. This very same idea also makes it harder for our immune system to fight off tumors. Cancerous cells are our body's own normal cells that broke down and went out of control. But the reason our immune system can't fight them properly is because those tumors can still possess our body's own antigens. There's a lot more to tumors than that, but it's one of the reasons they're able to avoid the aggression from our immunity. As a result, some of the viral antigens can be passed down. Another way our immune system gets antigens is when the cell overloads with viruses and dies. When the cell is dead, anything goes, and our immune system also takes care of breaking the dead cells down into pieces. This allows contacting some antigens. Anyways, I've made it sound a lot more complex and convoluted than what it is. Here's a simple recap. It's harder for our immune system to attack a virus and also to develop immunity against one. And humoral immunity is also less important than cell-mediated, but it can still be of use, especially when it comes to hepatitis B. So, let's now continue talking about hepatitis. It's a complex virus and it only affects humans. It's a very interesting virus from a scientific standpoint, but we'll not bother with in-depth details. What you need to know is that it has 4 main antigens: HBs, HBe, HBc, and HBx. The last 3 are not very interesting to us, but HBs is the one you'll hear about the most. It's a surface antigen that acts as a receptor to find liver cells and bind to them. Finding HBs antigen is the first test we do in order to confirm Hep B infection. If you test positive for HBs, you have hepatitis B, simple as that. HBs consists of 2 parts, pre-S1 and pre-S2. Pre-S2 is a receptor that binds with liver cells, and pre-S1 is a part of HBs antigen that we use for vaccination. Another idea that one needs to be aware of is that hepatitis B is a DNA-based virus. It's able to insert its DNA into our liver cells. There are 2 consequences to this. One is that the virus is incredibly difficult to get rid of, as it can forever remain in our liver, and 2 is that any major changes to our DNA can result in cancerous growth. Other than that, there isn't really anything to address in terms of vaccination. So, our source of infection is other humans, and our route of transmission is parenteral. It can be transmitted via hemotransfusions, sexual contact, injections, sharing items that can contact with blood, such as razors and toothbrushes, and vertical. It's the route of transmission from mother to child via placenta. What's troubling is that a lot of countries report high levels of hospital-acquired hepatitis B infections, and this is precisely why the hepatitis B vaccine is the first on our list. We've previously mentioned how newborn children may require blood transfusions, and it's the primary reason we administer hepatitis B vaccine extremely early. The clinical manifestations of hepatitis B infection vary significantly. Mind that the incubation period is 3 to 6 months, so any clinical manifestations of the disease will happen no sooner than 3 months into it. Biological markers of infection, however, can be found earlier. HBs test can become positive during the incubation phase even. Any liver pathology can be divided into acute and chronic, and so is hepatitis B. The most common scenario is acute infection persisting and turning into chronic. However, there are cases of acute infection and complete recovery, and the other cases of primary chronic infection. The first case scenario is relatively rare. As we mentioned previously, the virus inserts its DNA into the cells of our liver, and our immune system can't target DNA in any shape or form. The latter scenario of primary chronic infection is common among young children. While the first scenario is the most desirable, the latter is bad, as signs of infection can take years to manifest, and children's livers will keep silently dying to a point where treatment would be purely symptomatic. Acute infection can be represented as subclinical hepatitis, the one that has minimal clinical manifestations, acute hepatitis, and fulminant hepatitis, which is the most severe case, very often resulting in death. Chronic infection can be represented as asymptomatic carriers, liver cirrhosis, and liver cancer. Describing each one of those variants would consume a ton of time, and very often I'd just be repeating myself. So what I'm gonna do instead is list some common clinical symptoms associated with liver disease. Those symptoms will be more severe in case of an acute infection and may be absent completely in chronic cases, and vice versa. The liver detoxicates a lot of substances. It detoxes what we eat and drink, as well as detoxing byproducts of biochemical reactions in our own body. Most notably, it gets rid of nitrogen, which is a byproduct of protein metabolism, and bilirubin, which is the end product of the destruction of hemoglobin. The inability to detox nitrogen-based compounds results in higher blood levels of those products. And the issue with them is that they are toxic to our brain. This is the idea behind what's called hepatic encephalopathy. In acute liver failure patients, it can initially manifest as anxiety and agitation, but in severe cases it rapidly progresses into full-blown coma. In patients with chronic liver failure, the manifestations can be a little more subtle: mood disorders, nihilism, forgetfulness, and attention deficit. These symptoms are often very subtle too and require special psychometric testing to confirm. Either that or observing the patient over a long period of time. Often enough, relatives are the best tool when it comes to diagnosing these patients. They frequently report how there's something wrong in the person's mood, how they're way too sleepy all the time, or how they keep demanding snacks even though they've just eaten an hour ago. Over a period of some time, it gets much easier to diagnose, however. In acute liver failure, the same mechanisms are also the cause of brain edema, the toughest complication of the condition. It's by far the biggest issue with ALF patients, as more than half of them die to it. Patients who are in coma are at very high risk of developing brain edema and dying, and sadly, tackling the root cause is often impossible, as is the case of hepatitis B infection. Let me elaborate a little on why this is a problem for the people not savvy in medicine. The skull is a relatively small box, and our brain only barely fits inside. It's mainly filled with the brain itself and the blood that circulates around. If the brain starts to swell, it's gonna need a lot more space, and there's no way to make more space for it. Essentially, the only way the skull box can make more room is to reduce the brain's blood flow. Also, as the brain is getting increasingly swollen, it becomes much harder for the blood to actually supply it. But the most tragic thing that can happen is brain herniation. When the brain becomes too swollen, it'll start looking for other places to move into. The most common way for it to move is into the biggest hole our skull has to offer, foramen magnum. It's a place where our brain connects with our spinal cord. The problem here is that this part of the brain controls our cardiovascular system and respiration. If cardiovascular and respiration centers in our brain get damaged in the process, there's absolutely nothing that can save a person. Bilirubin is a byproduct of hemoglobin degradation. There's a rather complicated mechanism behind its detox, but we'll not dive into that now. High levels of bilirubin change the color of our eyes, scleras, and then also our skin to tones of yellow. Another big issue with bilirubin concerns the brain. At very high levels of serum bilirubin, it starts to penetrate the blood-brain barrier. Unfortunately, it can enter the brain but cannot leave, and the brain has no way of really dealing with it. This causes damage to neurons and is a primary reason why high levels of bilirubin are a terrible prognostic outcome. Serum concentrations higher than the said limit are associated with a very high rate of 2-year mortality. A particular case of high bilirubin levels is called cholestasis. This is when the contents of gallbladder cannot leave the gallbladder and enter the GI tract. In this case, you will see all of the above symptoms of high bilirubin plus white stool. Cholestasis also prevents bile acids from leaving and makes them enter into the bloodstream instead of the GI tract. This results in skin itching, and at high levels of bile acids, they are also toxic to the heart. Oh, and one more thing the liver is notable for detoxing is estrogens, female sex hormones. This is relevant in chronic setting, as men with cirrhosis will develop gynecomastia, i.e. grow boobs and lose libido, and vice versa for females. Their breasts will become smaller and saggy, and they will also become unable to menstruate. Our liver is the organ responsible for making all the blood proteins, aside from antibodies. The first relevant example is albumin. Albumins are blood proteins that help transfer compounds across our bloodstream and are also responsible for keeping osmotic pressure. When albumin levels and osmotic pressure drops, water in our blood starts leaving the bloodstream and going into other tissues, forming edema. This results in ascites. Ascites is fluid retention in peritoneal cavity. This is prominent for chronic hepatitis and cirrhosis and rarely occurs in acute setting. Low albumin and ascites are a problem for a few reasons. First of all, our blood loses water, and patients with cirrhosis often have low blood pressure. Low blood pressure is bad in general, as our organs can stop receiving the necessary blood supply. Moreover, the blood mainly loses water, but the cells and proteins remain in higher counts than normal. This predisposes to thrombus formation, which can cut the blood supply to organs and tissues. With large ascites, patients may start to experience stomach pains and lower appetite. Albumin is made from proteins, and if a patient with cirrhosis doesn't properly eat, then the problem creates a vicious cycle which will only get worse. Needless to say, moving around with a giant stomach also becomes an issue, and once ascites becomes big enough, it can make it tough for our diaphragm to contract. Diaphragm is our biggest and most important respiratory muscle, and if it becomes impaired, breathing becomes a lot more difficult for the patient. And number 2, our liver is responsible for all the coagulation factors. Without the liver producing them, our blood cannot properly clot. This is relevant for both acute and chronic cases, and massive hemorrhage is one of the leading causes of death in both acute and chronic liver failure. Something that every med school student looks out for in liver patients is the so-called Medusa's head. It's tied to another complication of liver disease that's called portal hypertension. Blood from certain organs flows into the liver through the portal vein. Once parts of our liver become damaged, it also becomes much harder for blood to flow through them, which can result in high blood pressure in the portal vein. If the blood can't flow properly through the portal vein, it has to find other routes. There are a bunch of places it can flow through, and those places manifest clinically as visibly dilated big veins. Commonly, it's the veins of anterior abdominal wall, which is the Medusa's head, esophageal veins, which are very often a source of massive hemorrhage in cirrhosis, and hemorrhoidal veins. This is something you'll see in chronic liver disease. The so-called small liver signs. These are not so common and are relevant for chronic infection. Palmar erythema, aka red hands, and spider nevi, aka spider angiomas. These are swollen blood vessels. They start to appear with progressing liver fibrosis and have been tied to the severity of liver damage. And finally, different kinds of GI upset can occur alongside all of these symptoms. Let's form a clinical picture of some of the most common problems one can face in acute and chronic liver failure. In acute liver failure, hepatic encephalopathy. This can range from mild, which presents as agitation, to severe hepatic coma. The worst of cases pose a high threat of clinically significant brain edema and herniation. Impaired blood coagulation. These patients don't present with massive hemorrhages, it's more of a diagnostic sign from tests rather than a clinical one, but these patients often die from severe bleeding from ulcers or during invasive medical procedures. Yellow scleras and skin from high bilirubin counts, stomach upset, kidney injury as a result of liver problems. It's a problem I never mentioned previously, but it's very clinically significant when it comes to these patients. In chronic liver failure, hepatic encephalopathy. It's generally milder than in acute cases and rarely progresses to brain edema. Often manifests as forgetfulness, mood disorders, and decreased attention span. Yellow scleras and skin from high bilirubin. Large abdomens due to ascites. Ascites also often manifests with complications such as low blood pressure and respiratory distress. Medusa's head, esophageal varices, and hemorrhoids as a result of portal hypertension. Problems with blood clotting. Combining the previous two factors makes for one of the most severe patient populations one can see in the ICU. See, as a result of portal hypertension, the veins in our esophagus and stomach can also get bigger. These are called varices, and the biggest issue with them is that they can rupture. Variceal bleeding is by far one of the most deadly issues one can face. First of all, these bleeds can go unnoticed for some time, sometimes lasting hours at a time before any symptoms manifest. Second, it can be very challenging to stop them, and clinicians often can't do that without using some harsh measures. Third, there is an incredibly high chance that the patient will bleed again. About a third of the patients bleed within a week, and secondary bleeds are always much harder to stop. Even the patients that do survive the ICU, they still have an incredibly high chance of variceal bleeding within the first year after. And every consecutive bleeding is generally much worse and much more difficult to stop. Infection is a giant issue for these patients. Not only is their organism already impaired quite a bit, but varices can get infected after bleeding and acidic fluid can also get infected. Kidney problems on top of chronic liver disease, stomach upset, smaller symptoms that I've mentioned previously. Needless to say, all of these issues pose a lot of challenges to a doctor. The treatment options in almost all of those cases are not straightforward, not simple, often ineffective, and also potentially dangerous. The only surefire way of getting rid of these problems is liver transplantation, and there may be contraindications for performing it. As far as hepatitis B goes, at the moment there is no good treatment. Again, it has a lot to do with our DNA, and the virus can potentially persist forever in our organism. Our immune system can sometimes fight the virus off completely after an acute infection, but we don't rely on those cases. There are a few drugs on the market that are effective against the virus. They don't kill it completely, however. In almost all of the cases, these drugs are taken as a lifelong treatment and help relieve some of the symptoms. You know what one of the worst things is about liver disease? I've mentioned forgetfulness a few times already, but now consider the context. A patient has to take pills for the rest of his life on a daily basis. If he doesn't do that, his disease gets worse. And actually, even if he does, it can still get worse, as chronic liver disease rarely stays in one place or gets better. Now, how sucky would it be if one of the patient's clinical symptoms actually led him to forget taking his medication? Well, I hope you catch my drift here. Hepatic encephalopathy is often a problem with these patients, as they may either forget to take their drugs or forget about taking their drugs and take too many, presenting with an overdose. These patients can also experience abdominal cramps and start taking random other medications to solve the issue. Acetaminophen is toxic to the liver in large doses, and bad things ensue when a patient with an already damaged liver consumes too much. Liver transplantation is not a viable option for hepatitis B patients as well. You see, we can replace the liver, but sadly the virus can persist in the patient's blood and simply infect the new one. Transplant patients also require recipients' immune systems to be suppressed, making sure there is no organ rejection. In immunocompromised patients, the virus is free to ravage the new liver as much as it wants to, and it's what often happens in those cases. As a result, liver transplant is not a viable option for hepatitis B. Now let's move on to the vaccine. As I've mentioned previously, it's a recombinant vaccine made out of pre-S1, which is part of the HBs antigen. The logic behind it is very simple. HBs antigen is a receptor that binds to liver cells, and we vaccinate our children to create antibodies for this receptor. Without it, the virus can't attack our liver. What's convenient about it is that we also monitor how protected we are by looking at HBs antibody levels. The recommended regime for vaccination is first shot at 24 hours after birth, second 1 month afterwards, and third 6 months after. It can be administered later on in life at any time using the same 0, 1, and 6 scheme. A few mentions about hepatitis B vaccine. From this point on, I'll be using World Health Organization's information sheets on the side effects of vaccination. These are the pooled odds of side effects from any vaccine in general, taken from clinical trials. The link to these sheets is available in the description below, and if you're curious about the information provided in them, there are references to studies and publications at the end of each single one. Let's take a look at what we have. Mild local reactions at a rate of 3 to 29% per 100 shots. High fever in 1 to 6 in 100 shots, and headache in 3 out of 100 shots. As far as serious reactions, there is anaphylaxis at a rate of about 1 in a million vaccinations. So, it's very safe, otherwise we would not be using it on newborns. There's no part of the vaccine that can lead to an infection or cause collateral damage too. A common contraindication to hepatitis B vaccine is yeast hypersensitivity, due to the way it's manufactured, which we discussed in the previous video. Now, I'll mention two problems with the vaccine. First, we're not completely sure how long the immunity lasts and how many booster shots might be required after the initial course. When I was vaccinated for hepatitis B, there were talks of 20 to 25 years of immunity, but given how this is a relatively recent vaccine on the market, we simply haven't had enough time to gather the necessary information. Don't let it discourage you though, as there is data being constantly gathered around, and when we get a definitive answer on whether we should be getting additional boosters, they will be included into the schedules. It's not a big issue, just make a mental note that 3 shots likely won't protect you for the rest of your life, and in the future there may be more boosters on the schedule. And another issue with it is the emergence of mutated strains. It's not an issue relevant to developed countries. The vaccine still covers at least 90 to 95% of circulating hepatitis B strains across Europe, but it's an emerging problem for Southeast Asia, where numbers as large as 50% of mutated strains were reported. The primary thing you need to be aware of is that the vaccine doesn't give you a 100% chance immunity against hepatitis B. Does that mean the vaccine is irrelevant? Absolutely not. Having a 90 to 95% chance of not developing hepatitis B infection after contacting the virus is amazing. Just for reference, in medicine in general, a treatment option is considered viable if it's effective at least in 70% of the population. Having 90 to 95% efficiency is amazing by those standards. One of the reasons I've delved so deep into clinical manifestations is to show you that there is nothing fun about liver disease, be it acute or chronic. While there is a chance your immune system will fight off acute hepatitis and recover, when it comes to small children the rate of developing chronic hepatitis B is about 90%. And our treatment options for chronic Hep B are incredibly scarce and their efficiency is incredibly low. The majority have to get lifelong therapy to reduce the symptoms and improve their quality of life, but the virus will never leave them. Should they stop, the disease will eventually progress to serious complications. So let's look at our scales. On the one hand, we have rare and mild complications of the injection, and on the other we have a disease with a very high rate of complications and associated mortality, and no real viable cure with limited treatment options. Which one is more dangerous is up to you to decide at this point.
Hello everyone, as you may have noticed, this video is coming out at a little bit later date than it was supposed to. First and foremost, it's a really large video, and I obviously needed a little bit more time to work on it, and the following video afterwards is also a pretty long one, so it may come out at a 2-week interval as well. The first 5 videos of this series were also made when I was on vacation and off from work, and now I'm back to work and I actually have a lot more work to do than previously. Also, there is a revolution currently going on in Belarus, as you may know. It takes a lot of time and attention away from doing any of the other things that I would like to, so it's also going to delay the series quite a little bit. I strongly suggest that you also follow the events in Belarus if you're into that, and especially support all the funds, spread the word, and help Belarusians fight off an oppressive regime. Hopefully, once this all settles down, the series is going to continue at rocket speed, and you're going to be seeing new videos every week. Живе Беларусь!